Hello, everybody. Today we are going to discuss gastrointestinal disorders and the different medications related to these GI disorders. Interestingly, a lot of patients you care for will probably be prescribed a GI medication while they are in the hospital, so you will see these medications quite frequently. Enjoy this lecture. Today we're going to talk about gastroesophageal reflux disease, otherwise known as GERD. We're going to talk about peptic ulcer disease. We're going to talk about nausea and vomiting, diarrhea, and constipation. Fun topics. Surprisingly, today, most patients that I have dealt with, and probably a lot of patients that you're going to deal with, they do have some sort of gastrointestinal problem that we need to medicate them for. Nowadays, there's a lot more people that are dealing with GERD, and a lot of them can go and self-medicate because a lot of these medications they can find over the counter at the local pharmacy. Let's talk a little bit about what is happening within the stomach. The stomach is really trying to maintain a healthy balance. And what am I talking about? Well, within the stomach itself, the stomach is really trying to maintain a pH level between 2 and 5. So what is happening within that stomach? We have some defensive factors, and that's going to help maintain that balance. We also have what's called pepsin, and that's a digestive enzyme, and that's going to be activated if the pH level gets too low, if it gets to about 2. So let's talk first about the defensive factors. Within the stomach, we have mucus, and this is going to be secreted by the cells within the GI mucosa, and this is really secreted to form a barrier, and it's going to protect all those underlying cells from all the acid in the stomach, and then if pepsin is being released in the stomach. Another defensive factor is bicarbonate. This is going to be secreted by the epithelial cells of the stomach and the duodenum. Most of it is going to remain trapped in the mucus layer, and what it's doing is it's trying to neutralize the hydrogen ions that penetrate the mucus. Within the stomach, too, we need to have good blood flow. So if we don't have that good circulation to the stomach, it can lead to ischemia, it can lead to cell injury, and it also puts the patient at risk for attack. Within the stomach, we also have prostaglandins, and these are going to be stimulated. They're going to stimulate the secretion of the mucus and the bicarbonate. So it's really trying to maintain that balance within the stomach. Then we have some aggressive factors that can cause problems within the stomach. One of those is Helicobacter pylori. This is also known as H. pylori. What in the world is this? Well, it's a gram-negative bacillus that can colonize in the stomach and the duodenum. Where does it live? Well, it lives between epithelial cells and the mucus barrier. And why can't our stomach destroy it? Well, it escapes destruction because of the acid. It can actually remain in the GI tract for decades. Half of the world is actually infected with H. pylori, but most people don't develop any symptoms associated with peptic ulcer disease. H. pylori can also promote gastric cancer, so we should keep that in mind. The most common thing that H. pylori can cause is gastric ulcers. Duodenal ulcers, much more common among people that have H. pylori. Well, what in the world do we do about it? Well, in order to get rid of it, we have to have an antibiotic, and that will help promote healing of peptic ulcer disease. We're going to talk more about that here in a minute. Other aggressive factors are going to be non-steroid anti-inflammatory drugs. I know we've mentioned this in past classes. These are those NSAIDs. Well, what does this have to do with the stomach? Well, We just mentioned prostaglandins are one of those defensive factors. Well, NSAIDs will actually inhibit the biosynthesis of prostaglandins, therefore going to decrease blood flow, decrease mucus, and decrease bicarbonate within the stomach. Another aggressive factor is going to be gastric acid. This can cause ulcers by directly injuring the cells of the GI mucosa and indirectly by activating pepsin. The increased acid alone does not increase ulcers, but it is definitely a factor in peptic ulcer disease. Pepsin is proteolytic enzyme in gastric juice. Another thing to remember is smoking. We have a lot of people that smoke in our community, and we should remember smoking can delay ulcers healing and actually increase the risk for reoccurrence of ulcers. So we need to keep that in mind when we're caring for our patients. So again, remember the defensive factors of the GI system. We have the gastric mucosal barrier, we have bicarbonate, prostaglandins, and one other one that we should mention is COX enzymes. So just a reminder, the gastric mucosal barrier, this is really one of those natural defenders to help protect the stomach mucosa from that acidity of all those lovely gastric juices that are flowing in that stomach. It's going to give a thick, viscous mucus material that's going to provide a barrier within the stomach. And the mucus is going to continuously be secreted within the cells of the gastric mucosa. Remember, it's just a protective factor. Bicarbonate, another protective factor. Remember, this is secreted within the stomach and duodenum, and most of the bicarbonate, it's going to remain trapped in the mucus layer. What does bicarbonate do? Well, it's going to neutralize any hydrogen ions that are going to penetrate through the mucus. It's going to help protect that stomach. It is also produced by the pancreas and secreted into the lumen of the duodenum, where it will help to neutralize acid delivered from the stomach. So it's given that protection in the duodenum also, which is part of the small intestine. Prostaglandins are going to be released as a protective factor, and it's going to stimulate the secretion of that mucus and bicarbonate. Remember these prostaglandins, especially for our patients who are taking those NSAIDs. We're going to talk about that in a minute. What do prostaglandins do? Where they're going to promote vasodilation, which helps to maintain that blood flow within the stomach. I didn't mention the COX enzyme before, but we should mention it now. So what exactly is this enzyme? Well, it's responsible for the prostaglandin synthesis in the stomach, specifically the COX-1 enzyme. So when we are thinking about this, some of the medications that we give, they are going to be prostaglandin inhibitors, those NSAIDs. An example of this is going to be ibuprofen. So how does ibuprofen work? Well, it works by inhibiting the COX enzyme. This is why people that have trouble with their stomach, maybe they have GERD, or if they do have a peptic ulcer, they really should stay away from NSAIDs. It could definitely cause more complications with their stomach. On this slide are common aggressive factors that can cause complications within the GI system. And these are things that are commonly used or common within our patients within society. So NSAIDs, a lot of people take NSAIDs. Our examples are Motrin, ibuprofen, Aleve. These are all over-the-counter products. What do they do? Well, they are prostaglandin inhibitors. Another common Complication, well, it can be a complication, but a common bacteria that is found in 60 to 75% of the patients with peptic ulcer disease, they have the Helicobacter pylori within them. Another aggressive factor is smoking. What does it do? It reduces the secretion of bicarbonate. It also can accelerate gastric emptying. And what's that going to do? Well, that's going to end up delivering more acid to the duodenum. So a common complication or a problem that smokers will complain about is that their stomach is giving them trouble. Well, it makes sense now, right? Let's talk a little bit about GERD. This is a pretty common disorder that a lot of patients are dealing with. And the thing that we should remember is now all of these products are found over the counter. So the patient can really self-diagnose, they can self-treat, they just go to the pharmacy and they can pick up the medications. Well, the problem with this is sometimes they forget to tell their healthcare provider. They forget to tell their family doctor, and now we may end up where the doctor prescribes another medication that could potentially interfere with these over-the-counter products. So very important for the patient to be telling their doctor what medications they're taking and why they're taking these medications, especially when they're taking these over-the-counter products. So GERD, what is this? Well, it's actually inflammation of the esophageal mucosa, and it is caused by reflux of gastric acid going back up into the esophagus. It does not necessarily mean that there's an ulcer that is being formed. A lot of times, the main cause of this is the lower esophageal sphincter. It's not staying closed and keeping the stomach contents within the stomach itself. So now the patient, that sphincter is opening up and all the gastric acid is backing up into the esophagus. So what exactly do we do for these patients? Well, like I said, they will go to the pharmacy, they can self-medicate. Really, though, they may not be taking the correct medications that are going to treat their problems. Plus, they really should know that lifestyle modifications can also help treat GERD. So it's not just taking medications. What medications should they be taking? Well, they should take medications to neutralize the gastric contents and also medications to decrease the gastric acid secretion, since that is what's causing the complications. It's that gastric acid backing up into the esophagus. Our patients with GERD should be aware of lifestyle modifications. So after they eat a meal, they should not go sit in their recliner and watch TV. They should maintain an upright position. They should be sitting up for at least 1 hour after eating. Another problem can be when they lie down in bed. It can cause them to have the gastric reflux at that time. So the recommendation is to elevate their head of their bed, and it's not to elevate using pillows. The recommendation is actually to take like bricks or something and stick the bricks underneath the legs of the bed in order to prop the bed up in the air. This is going to allow gravity to push the gastric acid back down into the stomach. Another thing that they should do is avoid medications that can increase their problems, such as medications that decrease peristalsis. We want to make sure that that stomach is emptying, it's pushing the gastric acid down, all the food down into the small intestine so everything can be digested. Another recommendation is to not allow that stomach to get too full. Well, how do we do that? Well, the recommendation is to eat small, frequent meals. So this means 6 meals a day. Doesn't mean to snack during those times. We're supposed to eat good, healthy foods. And this is actually that recommendation for all Americans. if you're following that healthy diet, Healthy People 2020. Another thing is, don't drink excessive fluids with meals. Another thing is weight loss. A lot of patients that are dealing with GERD, they are also dealing with obesity or being overweight. So if they can take off some extra pounds, it will relieve the pressure on the stomach, pushing that gastric acid back up into the esophagus. Let's talk a little bit about peptic ulcers. So an ulcer, if you've ever bitten your tongue or you bit the inside of your cheek, you may have developed an ulcer. So you've seen what an ulcer looks like. That's really what the ulcer looks like within the stomach. And I do have a picture there on your slide. Ulcers, when I'm talking about peptic ulcers, obviously now it's an ulcer that's in the esophagus. It can be in the stomach, or it can be in the duodenum, in that upper GI tract, the small intestines. And of course, the ulcer then, it's going to be an erosion of the mucosa layer. And you can see different causes, what can cause a peptic ulcer on that slide. With peptic ulcer disease, there's also recommendations for lifestyle modifications. Now, when you look at this list, it is very similar to the GERD list, and really you can use the same things when you're educating your patient with GERD or when you're educating your patient with peptic ulcer disease. Really, you can use the same recommendations. So on this modification for peptic ulcer disease, avoid foods that would exacerbate the symptoms. We used to recommend bland diets, restricted diets. We no longer do that. A lot of times it's individual for the patient as far as what are their trigger foods that can cause pain. Chocolate can be one of those trigger foods. Coffee can be a trigger food. Some people, milk can be a trigger food. I deal with GERD myself, and one trigger for me where I will get heartburn is if I will eat pretzels and drink milk. For some odd reason, that combination, not good for me. And when I get heartburn, it's not just a little bit of pain, it is gung-ho pain, and it really hurts. So I really have to be careful, and I try to avoid the foods. Another thing for me is overeating. So overeating, stretching that stomach can push the acid back up into the esophagus. Not a good thing. So that's why it's recommended to eat those small meals, because if they're trying to eat those big, large meals and they're stretching that stomach out, it's not good for the person with GERD or peptic ulcer disease. Another recommendation is to use alcohol in moderation. Some people, alcohol, if they drink one drink, it can be a trigger for them. So just be careful when it comes to alcohol. Smoking, we really should discourage that because we know that can worsen stomach problems. And then, of course, avoid those NSAIDs because they can inhibit the prostaglandins from being released, which again, increasing the risk for stomach problems. On this slide, you can see different medications that can be used to treat GERD and peptic ulcer disease. All the ones that are shown here on this slide can be bought over the counter at your local pharmacy. Next time you go, I suggest walking through the pharmacy aisles and just taking a peek at the different medications that are out there for the stomach, for the GI system. The one that is not found over the counter would be the carafate, sucarafate, and we'll talk more about that here in a minute. What type of medications do we use to treat GERD or peptic ulcer disease? Well, we can use antibiotics, we can use histamine 2 receptor antagonists, proton pump inhibitors, mucosal protectant, and that would be that carafate, antacids, and cytotec. There are 3 different ways that the anti-ulcer drugs will work. The first way is to eradicate the H. pylori if that is what is causing the ulcer. And of course, we'll use antibiotics for that. We'll talk about that in a minute. Another thing that we need to do is reduce the gastric acidity. Remember, the acidity is causing complications, worsening the problem, exacerbating the GERD or the peptic ulcer disease. And then we want to enhance the mucosal defenses within the stomach and really give that nice protective layer within the stomach, that defense mechanism that we need. The first thing we're going to do if we're going to eradicate H. pylori is we need to get the diagnosis that there is actually the H. pylori bacteria. So how do we test for that? Well, in order to diagnose either GERD or peptic ulcer disease, the patient's coming in, their signs and symptoms are they're having a lot of stomach pain, they're having indigestion, heartburn, and it's just not going away. A lot of times it's worse after they eat, it's worse at bedtime, so we need to figure out what's going on. So let's do some tests. One test that they can do is actually stick a scope down through the esophagus into the stomach. It's just a little tiny camera on the end, and they can actually visualize what's happening within the esophagus and the stomach, and then they can actually do biopsy samples with that endoscope. Another test that they can do is a breath test. Another one is a serologic test, so we can do a blood sample. And then another one is a stool sample. So antibiotics are going to be the treatment of choice if we discover that H. pylori is actually there causing the problems. So when it comes to treating H. pylori, we need more than one drug to treat it. Why? Because monotherapy will actually lead to resistance before we can actually eradicate that bacteria. So what do we do then? Well, antibiotic therapy, it's typically going to be combined with a proton pump inhibitor or a histamine 2 blocker. And the treatment for this, typically, it's not very long. It typically takes about 10 to 14 days, and then our patient is feeling better. Here's a list of some of the variety of combination of drugs that we may use to eradicate that H. pylori. I know we haven't talked about antibiotics yet. We will get to that during this semester, later on in the semester. Those of you that are in maternity, I know that you have looked up some of these antibiotics here that is listed on this slide. If you haven't had a patient that has been on any of these antibiotics, I would suggest looking up in the drug guide, becoming a little bit more familiar, because these are common antibiotics that we definitely use in the healthcare setting. So amoxicillin, tetracycline, clarithromycin, and then we have metronidazole, and that's your flagyl. And then remember, we're using combinations. So we're going to give other medications such as the proton pump inhibitors, the histamine 2 blockers, and then we can use Pepto-Bismol also. What does that do? Well, that will disrupt the cell wall of the H. pylori, and that will help to lead to lysis of that bacteria and then lead to cell death. And remember, that's what we're trying to do. We're trying to eradicate that H. pylori. So now let's talk about the medications that will reduce gastric acidity. A medication that we can use to reduce gastric acidity is that histamine 2 receptor antagonist, and we can use this type of medication to treat both GERD and the peptic ulcer disease. These medications are also called H2 blockers, and what exactly do they do? Well, they're going to block the histamine 2 receptor, and that is going to then reduce the gastric acid secretion and the concentration of the gastric acid. Remember, though, histamine has 2 types of receptors. I'm sure you've heard of histamine prior to this, and histamine 1 is going to be the receptor that produces those classic allergy symptoms. And we're going to talk more about those allergies when we are talking about the respiratory system and treating disorders of the respiratory system. So when we're talking about the stomach here, we're talking about histamine 2 receptors, and those are the ones responsible for increasing that acid secretion in the stomach. Receptor antagonists. Well, the first histamine 2 blocker that we had was Tagamet. Of course, this is available over the counter. We can go to the pharmacy, we can buy it. What exactly does this medication do? Well, it's actually a liver enzyme inhibitor. So when we have patients that are taking this, we should really make sure that they don't have some sort of complication with their liver, such as cirrhosis, liver cancer, any sort of liver disease. Also, patients that are taking phenytoin for seizures really should make sure that, they're buying it over the counter, but we should really be checking their med lists and making sure that they're not taking medications together that shouldn't be taken together. And remember, these patients, when they buy the over-the-counter, they're not even talking to a pharmacist. So it's very complicated when it comes to the over-the-counter medications and whether or not the patients are taking them correctly. We do have newer histamine 2 blockers, and again, these are now over-the-counter, and most of them are prescription strength. I know the Nexium, though, that's not prescription strength. But these drugs, the newer ones, are not liver enzyme inhibitors, so we don't have to worry about the patient with liver disease. And these medications would be Pepcid, Axid, or Zantac. Zantac is a common medication we'll use in the hospital, and in the hospital setting, typically we can use that as a piggyback medication. Other medications that we can use for peptic ulcer disease and for GERD are the proton pump inhibitors. These are the most effective drug groups that are going to help suppress the gastric acid secretion. So what exactly do they do? Well, they inhibit gastric acid from being secreted in the stomach. And again, we use that for GERD and peptic ulcer disease. We also will see the proton pump inhibitors being used in the ICU within the hospital, and we'll use these to prevent stress ulcers. Proton pump inhibitors, notice the common theme in the name, those generic names. Prazole is going to be the common theme in the proton pump inhibitors. This is your Prilosec, your Prevacid, Nexium, Protonix. And remember, how do these work? Well, they're going to reduce the gastric acid secretion within the stomach. When it comes to taking the PPIs, some things that we should recommend to the patients, this is how they should be taking these medications. They should be taking these at least 30 minutes to an hour prior to eating. And really, we want them to take this before breakfast, so before they put anything into their stomach for the day. When we are treating these patients, typically treatment, it's going to be limited to 4 to 8 weeks. Long-term treatment, it can cause some complications, and I can tell you there's a lot of people that are taking these medications long-term because, again, they can go and buy these things in the pharmacy, and they don't want to have pain in their stomach. So taking these medications, it is decreasing their pain. So they're definitely taking this longer than that 8-week time frame. Well, long-term treatment, it can increase the risk of hypomagnesemia within the body. It can lead to osteoporosis, can lead to fractures. So remember, we already talked about patients other patients that are at risk for osteoporosis are those women that are postmenopausal. So we really need to think about this. If we're seeing a patient that is a woman that is postmenopausal, we should definitely ask her if she's taking an over-the-counter product such as the proton pump inhibitors. The last way anti-ulcer drugs work is to enhance the mucosal defenses. So we're going to talk about that now. So what exactly do the mucosal protectant drugs do? Well, these are going to enhance those mucosal defenses within the stomach. Example of this type of medication would be that Carafate. We will use this in peptic ulcer disease, and this medication is non-absorbable. So what it will do is it can come in a liquid form, so it's already pre-mixed as a liquid. And remember, this is one that is not going to be your over-the-counter drug. This, the patient needs a prescription for, and it can come pre-mixed, and it's a liquid form, so then the patient is going to drink it, and it's going to form a viscous substance that covers the ulcer, and then it's going to protect that ulcer from acid and pepsid within the stomach. Remember, this medication is not going to affect the secretion of gastric acid. That's why we have to give the proton pump inhibitors along with this type of a medication. Some other medications that are over-the-counter products that can help with heartburn would be the antacids. And we have some alkaline substances, and what they do is they will neutralize the gastric acid. But antacids, the patient will chew them up and they'll swallow them, but really they're not coating that ulcer. It's just neutralizing the gastric acid. Why would a patient use antacids? Well, again, for GERD or peptic ulcer disease. And then the antacids, what would they be made from? Well, we'll have aluminum, magnesium, sodium, and calcium. So next time you go to the pharmacy, look at the antacids and see which ones are made from aluminum, which ones are made from magnesium, etc., etc. Some examples of the antacids that you can find: the aluminum hydroxide would be the Amphogel, calcium carbonate would be Tums, and if a patient is low in calcium, this is one medication. They could just take Tums to help build up their calcium levels. And of course, remember, it's those patients that are at risk for osteoporosis. They need to have extra calcium. So really kill two birds with one stone, right? Take Tums for the stomach, take Tums to prevent osteoporosis. Another example would be calcium carbonate with magnesium hydroxide, and that would be the Rolaids. Magnesium hydroxide and aluminum hydroxide would be the Mylanta and Maalox. And then we have sodium bicarbonate, and that would be the Alka-Seltzer. And these are all medications, the antacids, that you can find over the counter. Again, go to the pharmacy and take your little list along and look up these different things that we could buy over the counter to help with our stomach ailments. Antacids, why are they so great? Well, I've already mentioned how many times we can buy these over the counter, and they are very inexpensive. Sometimes the antacids can be combined with the histamine 2 blocker, and an example of this would be Pepcid Complete, and that would contain calcium carbonate, magnesium hydroxide, and famotidine. These medications, these antacids, are very safe unless a patient is taking these in extremely large amounts. So we would need to be aware of their kidney function. We want to make sure those kidneys are still functioning very good so they can clear these electrolytes out of their system. Another medication that can be used for peptic ulcer disease is a prostaglandin-like substance, and this would be Cytotec. Those of you that are in maternity, you should be very familiar with Cytotec, but of course we're not using it in maternity for gastric complications. So what does Cytotec do? Well, it will inhibit the gastric acid secretion, and it helps to stimulate production of that protective mucosa within the stomach, given that protective mucus. Why is the patient taking this? Well, we can use it for prophylaxis in patients who are taking high doses of NSAIDs, or if they're taking glucocorticoids. We will talk about glucocorticoids in probably a few lectures. We'll get to glucocorticoids. The one thing to remember about Cytotec, though, is that it is a pregnancy category X. And those of you that aren't in maternity, you're probably thinking, whoa, wait a minute, why are we using a category X medication in maternity? Well, it's because this drug will stimulate uterine contraction. So it's okay in maternity because we're inducing labor at the time. But now we got to think about, if the patient is taking this medication for a stomach complication, we have to worry about if it's a woman who is of age where she could potentially get pregnant. We need to be careful because she could end up miscarrying, all because this medication will cause uterine contractions. Now we're going to move on and talk about nausea and vomiting. Fun, fun, right? Nausea and vomiting. Well, let's talk first about nausea. Nausea is going to be that queasy sensation, and it may or may not precede somebody actually vomiting. And vomiting is going to be expulsing those gastric contents out from the stomach, out through the mouth. Not fun. It's never fun when somebody is vomiting. So why exactly does somebody vomit? Well, we do have a vomiting center. It's located in the medulla, and it will be stimulated. Sometimes it's because of a virus going on, such as the flu. It could be odors can cause vomiting, upsetting sights, pain can sometimes cause vomiting, different medications can cause vomiting. So when vomiting, the vomiting center is stimulated, what exactly is happening? Well, the motor neuron is going to respond by causing contraction of the diaphragm, those abdominal muscles, and the stomach. So then it's going to push all that food, those liquids, back out of the stomach. So what exactly do we do for our patients if they are vomiting? Well, we do have medications, and they're going to be called antiemetics. And there's different classes of drugs that we can use. Serotonin antagonists, we can use dopamine antagonists, benzodiazepines, anticholinergics or antihistamines, and the cannabinoids. Within the brain, when somebody is going to vomit, so triggering that vomiting center in the brain, another center in the brain is going to be a chemoreceptor trigger zone, also known as CTZ, and that's again in the brain, and that's also going to cause vomiting. So we can give serotonin 5-HT3 receptor antagonists. And what exactly does this do? Well, it's going to act on serotonin receptors in the intestinal wall, going to act on the stomach, and it's also going to act on that chemoreceptor trigger zone in the brain, that CTZ. A lot of times we'll use these type of drugs for post-operative nausea and vomiting. We can also use these medications for patients that are receiving chemotherapy. A common side effect from chemotherapy is nausea and vomiting, and that is not very good for these patients. They don't feel they don't feel well, they're going through treatment, and now the medication is causing them side effects. So if we can make them comfortable, we're certainly going to do that. So Zofran is an example, and Aloxi is another example. Commonly, we are going to use this. Zofran more common than the Aloxi. A lot of times we'll give the Zofran, we can give that ahead of time. If we have a patient scheduled for a surgical procedure, we can do that pre-op, and then we can also use it in the PACU. If somebody has just had surgery too, they're already not feeling good because now we are causing them pain because now they have an incision of some sort and they don't want to be dealing with nausea and vomiting. We do have some adverse effects of these types of medication. It could cause a headache, dizziness, or drowsiness. A lot of times drowsiness is the most common side effect. And if they just had surgery, the best thing they can do right now is rest. So it is okay that it causes a little bit of drowsiness. Other types of medications that we can use as an antiemetic are the dopamine antagonists. How do these work? Well, they block the dopamine receptors in the brain at that CTZ site. These medications also have anticholinergic and antihistamine effects. So remember those anticholinergic side effects. Anticholinergic is going to be against the parasympathetic nervous system. So anti-parasympathetic nervous system is really going to equal to a sympathetic response. So remember that if we are using a dopamine antagonist, all those different sympathetic responses that the patient could now have as a side effect. Some examples of dopamine antagonists would be Haldol. And remember, we had talked about Haldol when we talked about medications that affected the central nervous system. And remember, we talked that is a common medication that we'll use for chemotherapy patients to prevent the nausea and vomiting. Compazine is another dopamine antagonist. Phenergan we used to give a lot in the hospital. I gave Phenergan so many times, I can't even count how many times. And we used to give the Phenergan IV push. Well, it is no longer to be given IV push. It can still be given IV, but it should be mixed and given as a piggyback medication instead. And we really need to make sure that IV is not infiltrated because this is one of those medications that can cause harm if that IV is infiltrated. We can cause extravasation in that tissue around, and I've seen patients, pictures of this. I never had it happen to me, but I've seen pictures of patients that had Phenergan IV push and it got into the tissue surrounding that vein, and it actually caused necrosis to the vein. So we should no longer give it IV push. Phenergan also has a black box warning for respiratory depression. A common side effect for Phenergan is that it will make the patient tired. I used to give it all the time in maternity. Our patients that would come in and, they were having contractions, but they weren't really progressing. And sometimes the midwife would order a pain medication mixed with the Phenergan in hopes that the patient could go home for a little while, get some rest at home, and then after they have gotten that nice rest, then come back in. The hope was that they were actually in labor then, and their cervix was dilating, and then we could have a nice labor where she was well rested prior to coming in. Phenergan is also contraindicated in children under 2, so we should never give this medication to a pediatric patient less than 2. Reglan is another common medication that you'll see in the hospital setting. This is a prokinetic agent, and it actually increases GI motility. So if we have somebody that has problems with gastric emptying, this is a good product and it comes in a PO form, and it can help to empty that stomach out so they don't have that full feeling all the time. Reglan is contraindicated with a GI bleed, or if a patient has an obstruction or a perforation. We wouldn't want to be pushing more food down through the GI system if they have these complications. Other antiemetics that we have available would be benzodiazepine, and these would be Ativan or Valium. We've talked about these medications in the past also. We can use these medications. They're centrally acting medications, so we talked about these during the central nervous system lecture. And we can give these for anxiety also, but in this case, it's going to be preventing nausea and vomiting. Ativan, commonly we'll see this being used prophylactically to our cancer patients prior to those chemotherapy treatments in order to prevent the nausea and vomiting that chemotherapy can cause. Anticholinergic medications can also be used. A lot of times we'll use these medications for our patients that experience motion sickness. These would be somebody who maybe they're going on a cruise, and a lot of people get motion sickness on a cruise. Could be used if somebody gets motion sickness in a car. Typically we'll use these prophylactically. It definitely works better to treat them with the medication prior to them getting sick. We don't want to wait for those symptoms to come on. When we use these medications, we should expect anticholinergic side effects. Example of an anticholinergic would be scopolamine, and this comes in a transdermal patch, and typically this is the way we'll use it. We do have oral route or sub-Q routes, but the most common route that I've seen is the transdermal patch. I've seen this medication being used a lot preoperatively, and they'll use it for patients that in the past anesthesia has caused them nausea and vomiting. So we'll put it on preoperatively, and it goes right behind the ear. It's pictured there on your slide. It goes right behind the ear, and that will stay on until the post-op period. Just make sure, though, before we discharge these patients from the hospital, we take that patch off. And typically in the MAR, they will have a stop time, and then that will remind the nurse that she has to go in or he has to go in and take that patch off. We really shouldn't be sending these patients home with these patches because it continuously releases the medication to them, and we wouldn't want them to have that on once they get home. Other medications we can use as antiemetic would be antihistamines, and these are going to decrease the stimulation of the vomiting center. These medications also will block acetylcholine, so again, we need to watch for those anticholinergic side effects. We'll use these medications for motion sickness. We also can use them for post-op nausea and vomiting. So Dramamine, that can be found over the counter. Benadryl, that is an antihistamine, so we'll use that for allergies, but it also can be used for nausea and vomiting. So those patients, if you experience motion sickness, Dramamine is a lot more expensive than Benadryl. And you can use Benadryl, take 1 or 2 tablets prior to getting into the car, or maybe you get sick on amusement rides. Benadryl works just as good. The only problem with Benadryl, though, but you still get this side effect with Dramamine, is sleepiness when taking it. So, but if you're going to an amusement park, you're going to be having fun and you're not going to be thinking about being tired. So Benadryl, it is a cheaper choice, just to let you know that. Other antihistamines, Vistaril, we also have Antivert. These medications would be by prescription. I've given Vistaril already, and I've used that as a combination given with Demerol, and I would give either IV or IM, and Demerol and Vistarol can be mixed in the same syringe. If you're given an injection, then you only have to poke your patient once. Well, nice thing about that is we're relieving the pain with the Demerol, and then we're preventing nausea and vomiting that the Demerol can cause by giving the Vistarol. So it does work nicely, giving the pain relief for a patient while not causing them side effect of nausea and vomiting. Cannabinoids are going to be related to marijuana, and we got to think about these. They can produce the same subjective effects that are identical to those caused by smoking marijuana. So when we think about these type of drugs, there is some potential for abuse. Example would be Marinol, and this is a Schedule 3 drug, so that means there is a potential for abuse, less potential than the Sesamet, that's a Schedule 2 drug, so more likely that the Sesamet will cause abuse. I've never seen these medications being used, but since we're living in Colorado and marijuana is legal in Colorado, I have heard of patients that are they're going through chemotherapy, and I've heard of patients using marijuana to prevent nausea and vomiting after chemotherapy treatments, just to prevent that nausea and vomiting, preventing weight loss because it also helps to get their appetite back. So maybe some positive effects from legalizing marijuana. So cannabinoids, they are related to marijuana. So the cannabinoids, they are also commonly given for those chemotherapy patients to prevent that nausea and vomiting. Also, these medications can help stimulate appetite. So same thing as marijuana here in Colorado. And our chemotherapy patients, they really don't feel good. They're going through cancer. A lot of them experience weight loss just because of going through their treatments. And if we can maintain their weight at a regular level, we can help with healing. And especially, remember, have them eating the protein to help heal their cells and promote wellness with our patients. We also can use the cannabinoids for our aid patients, and again, it's to help with nausea and vomiting, also help to stimulate their appetite. If our patients are using these type of medications, they should be avoiding alcohol, also avoiding any other central nervous system depressants, because these also depress the nervous system. Let's talk about diarrhea and constipation now. Just what you wanted to talk about, right? When you're taking care of patients, you may have a patient that is experiencing diarrhea. Remember, diarrhea is a symptom. It is not the syndrome or the problem. So we need to figure out what is causing the diarrhea. We do have antidiarrheal medications available, and many of them are available over the counter. So again, the patient can go and buy these at the local pharmacy. A lot of times we have patients that are taking the over-the-counter medications first, so it does often delay that medical evaluation because they're self-treating at home prior to coming to the hospital to get treatment or going to their doctor. So what is the most serious complication of a patient having diarrhea? Well, obviously, they're putting out an awful lot of fluid very quickly, so it can definitely lead to dehydration. We really need to be thinking about dehydration with that fluid loss. We can also use opioid agents to treat diarrhea, and these are the most effective agents, but it's not the most common medications that we will use because we do have over-the-counter medications instead. With the opioids, we got to remember they could be habit-forming, except the Imodium. Imodium, you can find that over the counter. That's one that is found over the counter. So what exactly do they do? Well, they cause a decrease in intestinal motility, so it's going to slow down the transit time. It allows for that water that is in the large intestine to be absorbed back into the body to stay in systemic circulation. A side effect that can be caused from giving the opioid agents would be rebound constipation. So now instead of having diarrhea, now they're having constipation. Other medications that we can use for diarrhea, Lomotil. The only indication for this medication is for diarrhea. If given at appropriate doses, it's not going to affect the central nervous system. We do have very low risk of abuse. If taken in high doses, now we would have undesirable effects. So we want to make sure the patient's taking this medication as it is prescribed or as it is recommended as the over-the-counter medication. This medication is a Schedule 5 drug. A more common medication that you're going to see is Imodium or kaopectate. And these medications, they are an analog of Demerol. I mentioned Demerol earlier as being a pain medication. With the Imodium, there's no narcotic or analgesic effect, but if given in high doses, it can cause respiratory depression. So we need to think about that. Make sure the patient is taking the medication as indicated. This medication is not regulated under the Controlled Substance Act. Another medication used for diarrhea is bismuth subsalicylate. Examples of this would be Pepto-Bismol or kaopectate, and these medications you can find over the counter. So how do these work? Well, they're going to stimulate absorption of fluid and electrolytes across the intestinal wall to hold those back in systemic circulation. With these medications, they also will absorb large numbers of bacteria and toxins. So maybe it's the bacteria that's causing the diarrhea. So now it's going to absorb it back into the body. These medications can impair absorption of other medications, so we want to be careful if the patient is taking other medications. Another potential complication would be that these medications contain aspirin. So we would want to make sure that if the patient has coagulation disorders, we would want to use this medication with caution. If the patient overdoses on Pepto-Bismol or kaopectate, possibility of salicylate toxicity could occur, and this would be tinnitus would be their sign and symptom, and that would be with an overdose, so they should not be taking too much of this medication. I've seen patients that have had Pepto-Bismol and they take it. I used to do home health, so I used to see patients in their home. I've seen patients take the Pepto-Bismol bottle, and instead of measuring it out into the appropriate dosage, they just take the bottle and they chug it down, and they should not be doing this. They need to be measuring it out. So we should educate the patient if we would ever see this happening. Now let's talk about another GI complication, and this would be constipation. So what exactly is happening? Well, now the patient can't have a bowel movement. Why is this happening? Well, maybe they're not getting enough water intake in their diet. Maybe they're not eating good food, so they're not getting that good fiber in their diet. Maybe they're immobile, or they're just a couch potato, and so they're lacking exercise, which is slowing down peristalsis. Or maybe they're using medications such as opioids or anticholinergics, Remember, a lot of patients in society nowadays are using opioids, so we really should remember opioids definitely can cause constipation. So good education with these patients. Make sure that they're not experiencing constipation. So what can we do for our patients? Well, there are some non-pharmacological treatments that we can recommend to our patients. So increase the amount of fluid in their diet, especially water. Make sure they're getting exercise. And remember, these are all in the guidelines. Healthy People 2020, get up and start moving. So get active again. And then have a diet that has that bulk in it, that it has fiber in it. This will help the patient move their bowels. The different categories of laxative agents would be bulk agents, surfactant laxatives, stimulant laxatives, and osmotic laxatives. We have some medications for constipation, the bulk forming laxatives. Examples of these would be Fibricon, Citracel, Metamucil. These all can be found over the counter. What exactly are they? Well, they're indigestible substances. They are non-absorbable, so they stay within the digestive tract. They give that bulk in the digestive tract. They're made of natural fibrous substances. And what exactly are they doing? Well, they're going to soften the fecal mass. They're going to increase its bulk. And it also is going to cause an increase in peristalsis to move it out of the GI tract. So if we have a patient that has constipation, this should be the first line treatment. And why is that? Well, we can use this as a long-term solution if the patient is constantly experiencing constipation, but we could also use it short term if this is just an acute issue. Using the bulk forming laxatives can actually reduce the risk of colon cancer. Interesting, right? We do have some adverse effects, potential adverse effects using the bulk forming laxatives. Remember, they're not absorbed, so we don't have any systemic effects, but we could possibly have esophageal or intestinal obstruction being caused because remember, these are staying within the GI tract. When would this occur? Well, if the patient is not taking in enough liquid in their diet, well, now it can cause within the GI tract, all of this substances can solidify. And again, this could lead to that obstruction. Other adverse effects is these medications are not dependence forming. Patients that have hypercalcemia, they should avoid Fibricon. And then these are contraindicated in patients who cannot drink lots of fluid because we know that could possibly cause an obstruction. So how are these medications administered? Well, they come in powder form and then we mix with a juice or with water, stir it up really good and get it to dilute in that water, and then they need to drink it immediately. If they let it sit, it's going to solidify in that cup. We don't want that to happen. We want to get the substance into the patient's body. Another type of medication that can be used for constipation would be surfactant. And these type of medications would, how do they work? They're going to promote water accumulation in the intestine. So keeping that water in that large intestine. Examples would be Colace or Surfact. Colace is very common. We use that a lot in the hospital setting. So I can bet you're going to have patients that are going to be prescribed Colace. A lot of times we're using these as prophylactic treatment. We can use it following a myocardial infarction. Why would we use it for them? Well, if they've had a heart attack, we do not want them straining to have a bowel movement. So this is going to help them have that nice, solid, soft bowel movement and easily pass it out of their body without straining. Other reasons why we would give it is for surgery. Again, we don't want them to be straining after a surgery. We use it a lot in postpartum. For our patients that have had vaginal deliveries, we don't want them straining and pushing on their perineum. We can use these type of medications for our elderly patients. If they cannot drink enough fluids, remember, we don't want to give them that bulk laxative. So now we have another option. We can give them Colace instead. Another type of medication that we can use for constipation would be a stimulant. And these medications, they are going to be contact laxative. What do? Well, they're going to increase peristalsis within the intestines. So they're definitely going to help the patient empty out. Examples would be Dulcolax, X-Lax, castor oil. You can find these over the counter. Problem with these medications, they are used frequently and they are abused, especially the Dulcolax and X-Lax. If a patient has constipation, these type of medications should only be used short term. These should not be a long-term solution for constipation. A lot of times the patients that are abusing it, it's the patients that are trying to lose weight, and that's not good because now they're causing diarrhea, so they're causing their intestines to empty out really quickly in hopes that they don't absorb all those calories in the food. So they're trying to use it as a solution for weight loss, and really that's just a temporary solution because ultimately what it's doing, it's dehydrating our patients. It's not good. You can go to YouTube, you can Google patients that abuse laxatives, and there are quite a few videos out there that show people that are abusing it and talking about it. So we definitely don't want our patients using this as a long-term solution or using it for weight loss. That's not why it should be given. Osmotic laxatives can also be used for constipation. What are these? Well, these are saline laxatives. They are poorly absorbed salts, and what they do is cause an osmotic action that's going to draw the water into the intestinal lumen. So what's happening in the intestines? Well, water's accumulating there and causing the fecal mass to soften. It's causing it to swell, which then leads to increased peristalsis to try to push that out of there. So examples of these would be milk of magnesia, or fleet phosphosoda. I've seen these being used in the hospital setting. You can also purchase these over the counter. The osmotic laxatives, they do come in a liquid form, so if you ever have to administer these to your patients, make sure you're measuring out and giving the correct dosage to your patient. You're going to use a medicine cup to measure it out in, and make sure you look eye level and make sure it's being measured accurately. Sometimes they'll come up from the pharmacy pre-mixed in the right amount, so you don't have to do any measuring. So what are some adverse effects from these? Well, it can cause substantial loss of water. Remember, they're pushing the water into their intestines, and then it's coming out with their bowel movement. So the patient should be replacing that fluid loss. So now they have to increase the amount of fluid that they're taking in, that they're drinking. Other adverse effects are small amounts of sodium and magnesium will be absorbed. So if we're administering the magnesium product, we need to monitor renal function. And those magnesium salts, they are contraindicated in any patient that has kidney disease. Why? Because magnesium can actually accumulate and become toxic within the body. Not a good thing. If we're administering a sodium product, sodium absorption can cause fluid retention. So now those sodium salts, they are contraindicated if we have a patient that has heart failure or hypertension. Remember, the body, an abnormal condition is occurring now, and we do not want to cause a worsening complication. If they're holding on to the sodium, remember water is going to follow, and now it's going to stay in systemic circulation. It's going to put pressure on those vessels, and now it can lead to hypertension. It can weaken the heart. So we don't want to worsen the patient's condition. We want to make sure that we're not causing any complications. Another medication that we can use to help empty the bowels, and typically this is going to be given for a bowel prep. What does that mean? Well, that means your patient is going to be going for a colonoscopy. Remember learning about colonoscopy in fundamentals? Well, I remember when I used to work on a med-surg unit, I used to give Go Lately a lot, and oh my goodness, it's such a pain giving this medication. Why? Well, because if you see there, the patient has to drink about 4 liters of fluid, and this needs to be done over 3 hours. So how much are they drinking? Well, every 10 minutes, I would have to go in and pour them a cup, and it should be 240 milliliters. Every 10 minutes, they're drinking it. Well, guess what? We're trying to completely clear them out. So now they're drinking all this, so we're spending a lot of time in there getting them to drink this. Well, now they're up all night going to the bathroom, emptying out, because everything needs to be out of their GI tract. This solution is isotonic. It's non-absorbable. It's not going to pull water or electrolytes. It's just going to cause this fluid to go straight to the GI system. The nice thing about this is we can give this medication to patients with renal impairment or congestive heart failure. But with your congestive heart failure, be careful because, you know, it's a lot for them to drink at once. But it should all be staying within their GI tract. So we really shouldn't have to worry about fluid overload in that case. Miralax is an osmotic laxative, and this is another medication that we'll use as a bowel prep, so emptying everything out prior to a colonoscopy. Miralax, the nice thing about this is it's over the counter, so the patients, they don't need a prescription, they can just go buy Miralax, and they can do this bowel prep themselves prior to having an outpatient colonoscopy. Well, how does it work? Well, it's going to hold water inside the intestines, and it's going to soften the stool. Well, what's that going to do? It's going to then stretch the intestinal wall because we have this bulk in there, and that's going to stimulate peristalsis. So it's going to increase the number of bowel movements. So for the bowel prep, it's going to be used in high doses because we need everything to empty out. We also will use it for surgical procedures. If they're going to have any type of intestinal procedure, we need that to be, their whole intestines to be emptied out prior to the surgery. Some adverse effects, though, it could lead to dehydration, nausea, or flatulence. Remember, after a colonoscopy in the PACU, if you get to go to the PACU and see the colonoscopies, an expectation afterwards, before they can go home, is they have to be passing gas. So we have to make sure everything's going back to normal and peristalsis is occurring and that they're able to pass the gas so they don't get filled up with that gas. So medications causes the flatulence, but now in the post-op time, we need to make sure they're passing it out. Lactulose is another medication used for constipation. This is poorly absorbed and it can't be digested, so it's going to draw the water into the intestines, and now it's going to form a soft stool. This is a good laxative, but it is more expensive to the other medications we've talked about. Another thing is that lactulose will pull ammonia into the bowel, so it's going to decrease the serum ammonia levels. So this is going to be useful for any of those patients that have liver disease. Whew, Woo, we made it through that lecture and talking about the GI system and different disorders and different complications that go along with the GI system. So now let's go over some NCLEX questions. Which of the following is a priority for the nurse to administer to a client with GERD, gastroesophageal reflux disease? Gastroesophageal reflux disease. Do we need to give antibiotics? Do we need to give anticholinergics? Well, the correct answer is going to be the proton pump inhibitors. Remember, these people, they're experiencing the acid refluxing back into their esophagus, so the proton pump inhibitors are going to decrease that gastric acid. When the nurse teaches a client about the side effects of anticholinergic medications, what signs or symptoms should be included? Anticholinergic, is that working on the parasympathetic or the sympathetic? Anticholinergic. Remember, that's against the parasympathetic nervous system. So now we're going to see the sympathetic nervous system responses. If you guessed A, you're correct. Remember, sympathetic response is going to cause urinary retention, constipation, dilated pupils. Remember, sympathetic patients fight or flight, running from that scary monster. They don't want to have to stop and go to the bathroom. The nurse evaluates that medication teaching has been effective when the client states that Zantac, what does Zantac do? Remember, Zantac is going to decrease gastric acid levels, so the correct answer is A. We didn't mention this when we talked about Carafate, but let's see if you know the answer. Which of the following should the nurse include in the teaching plan for a client taking Carafate? Now remember, this is the medication that they're going to drink. It's in liquid form, and it's going to form that protective barrier in the stomach and protect those ulcers. So what do you think? What's the correct answer? If you guess C, you are correct. So if we're administering the Carafate, we should make sure we're not giving it with other medications, and we don't want them eating with that medication either, because it's forming that protective layer in the stomach. It's protecting that ulcer and allowing it to heal. So we need to make sure we're doing separate administration of the Carafate with other drugs by 2 hours. Let's see if you know this one. After obtaining a medication history from a client who informs the nurse of her early pregnancy, which of the following drugs is a priority for the nurse to obtain in order to discontinue? So now we have a pregnant patient and we're trying to discontinue the medication. Why would we discontinue the medication? The correct answer is A, Cytotec. Remember, Cytotec is a pregnancy category X. Why? Because it causes uterine contraction. So if we have a patient that is in early pregnancy, we don't want her taking Cytotec. That can lead to a miscarriage. So definitely we need to stop that medication.